Welcome back to the True Sports Physical Therapy Podcast. Today is just going to be me. So let me just introduce myself. If you don't know who I am, my name is Yoni Rosenblatt. I'm the owner, CEO of True Sports Physical Therapy. We have clinics throughout Maryland, Delaware, Pennsylvania. And what I did today was I just asked our audience of the thousands of PTs that listen to this podcast across the world. It's really gratifying to see so much input. What kind of questions do you want answered? And I think we're going to start doing more of this, depending upon your feedback, of an AMA episode. Just ask me anything, and you'll hear me just talk about it, almost like I'm interviewing myself, but they're questions from you guys. So today is just me. We got a number of very exciting episodes coming up. If you're new to the podcast, kind of shoot back and look at some of the studs that I've had on this podcast. We're talking about stars like Kelly Starrett, Derek Hansen. We're also talking about some unbelievable physical therapists in the private sector. We got Dr. Tim Stone, a few from Dr. Austin Kolish. I just did one with Dr. Kendra Lennon. Just outstanding studs that I work with day in, day out, who have taught me a tremendous amount, and I know they're teaching you a tremendous amount. So do a deep dive kind of in our backlog and let us know who you want to have on next. I can't wait for some feedback on how I did today. Without further ado, here's me answering your questions. All right, guys, welcome back to the True Sports Physical Therapy Podcast. Today, it's just me, but it's me with your input. What we did was we put out kind of a call to action to all the thousands of people that follow us on Instagram, that listen to the pod, and we wanted to know what it is you guys wanted to hear. How can we, True Sports Physical Therapy, bring you guys value? And so we solicited questions, and you guys responded in mass, and there were a few buckets, few bigger question items that I'd love to address and kind of walk through. So it's going to be a lot of my nasal voice, but hopefully it's going to resonate with some of these questions that you posed and give you some direction, whether it be how do I handle the patient in front of me? How do I create buy-in? How do I create compliance? We're going to talk about all those things in today's episode, the Ask Me Anything episode. So I want to get rolling with the following, and forgive my stream of consciousness. You'll probably hear me talk a little bit more colloquially than professionally, but hopefully it lands. Here we go. What is one common mistake you see athletes or active people make when trying to recover on their own? So I think this is a great question because there is so much information readily available to our patients. And so I got to ask myself, why the hell is this patient coming in to see me? What value am I providing them that they can't get either on the web, from ChatGPT? There's so much stuff out there. They can just subscribe to a program. Why do they have to come and see me? And I think that is where my obsession with attention to detail comes in. Let me get into what I mean by that attention to detail. Number one, when that patient walks in the door, that is when your evaluation begins. You're going to look at how they walk back to the treatment room with you. You're going to look how they sit in the waiting room, how they fidget, how they're moving. And what you're trying to do is you're trying to build an entire case that can explain to them why it is they're having the presentation that they're having, whether it be what's causing their pain or what's causing their lack of productivity on the field or on the court. You want to be able to answer their questions based upon your observations, ideally objective observations, but even subjective observations like, hey, you're standing in front of me. So before we even get started, I want you to just look down at your feet. You realize how your left foot kind of sits out at an angle versus your right foot. That could be because of a tighter Achilles. You're trying to compensate for that Achilles being on stretch if your foot were in neutral. Now, maybe that's coming from a hip external rotation, but maybe it's coming from the ankle. You're going to back that up with your objective measurements and say that you're missing this amount of dorsiflexion, and that's why you're sitting out at this given angle, or your active to passive ranges. There's a major discrepancy there, but you're building detail into that observation that is vastly different than so much of what they're going to get online. So I think that's one big mistake, is they think they can get these answers online and maybe it's not working for them. If we're paying attention to detail, then we can really start to identify why they should be coming in, what's causing their pain, why they should come back for visit 2. So that's one piece of attention to detail. The other attention to detail that they may not be getting is, if they're signing up for a program online or trying to fix things themselves, the detail in how that program is manipulated as the patient is going through their rehab process, that falls on you, the clinician. Your ability to pull different levers when treating a given patient, and maybe it's adding more reps, maybe it's adding more weight, maybe it's increasing range, but whatever it is, it's for a directed reason. That is based upon not the detail when they walk in. That is based upon the detail and preparation in preparing for the session, or when summarizing the session or going back over the session. Maybe you're writing your note later that day and you're putting together the plan for the next time. You're going to understand exactly what levers to pull, how to progress or regress a given intervention, manual or therapeutic exercise, strength and conditioning principles, to get them to the goal as rapidly as possible. Again, maybe that's getting out of pain, or maybe that's becoming a higher level performer on the field. I also want to shout out some specifics. I currently subscribe to a strength and conditioning program by Joe DeFranco. It is an unbelievably simple strength and conditioning program that I follow for my own fitness. The reason I call this out is because he has done an awesome job of making a catch-all, of making very safe, easily explained exercises very hard to get hurt doing those things. That is awesome for the regularly healthy athlete. But remember, the people walking into your door, there is some nuance there. And so understanding those details, that's a mistake that I commonly see both on the clinician side, and definitely it's very hard to understand how I'm performing a given movement in the gym without skilled or trained eyes on me. So I think that's a big mistake that you can overcome with that prescription of paying attention to those details. Next, hopefully that answers your question. Next question is, how do you balance pushing an athlete or patient forward without risking overloading their tissue or slowing recovery? And this is a tough one. I think sometimes it takes a seasoned clinician. It definitely takes a well-researched and organized clinician to understand when to push, when to dial back. So this is what, I hate on um, the how tedious our profession can be, and that we have to write a note with every single patient, and we have to jot down all this garbage inside of your electronic medical records so that the insurance company can see what you did and you get paid. But also making sure that you put in worthwhile notes as to how a patient responded to your given intervention. That gives us the fodder upon which we can base our next intervention. That's how we should determine whether to push the patient, whether to dial back the patient, whether to change a given exercise in a very specific way. I think that's a great way to try to make educated guesses. And also, you need to be coming at these prescription points when you're asking a patient to say, hey, I know we did 3 sets of 10 last time. Today we're going to do 3 sets of 12. Or I know we did 65 pounds. Today we're going to do 65. Or I know we did 60 pounds last time and it flared your knee up. I need to be humble enough to say, I screwed up on that a little bit. So why don't we dial it back? We're still going to get some load through the tissue. We're not going to increase the weight, or we're going to decrease the weight, but we still want to get some type of strength input into the muscle, or challenge into the muscle to encourage it to grow, something like that. You have to be humble enough to say, I push too much. I recently had a patient that is coming back from ACL and really flared up with a whole bunch of patellar tendonitis. And I, looking back at it, if I can look back at my records and understand, hey, we got to plyometrics too rapidly, or we got to change the direction too rapidly, or maybe I didn't hit the proper testing prior to that, or maybe he did well in one session and I ramped up immediately next session instead of just repeating what I did, maybe adding some other accessory muscles onto it. We have to be okay enough, one, to have the objective data to go back and say, oh, this is what I did incorrectly, but also I made a mistake. I thought we were ready for this. We weren't. Let's see if we can shift gears a little bit to give that patellar tendon time to calm down. I'd like to think it happens to the best of us, but that open line of communication, all of a sudden, that's going to engender trust with your patient, with the athlete in front of you. That's going to allow him to say, okay, we pushed a little too much. This is part of the process. This was explained to me day one coming out of ACL that rarely is it a straight line from I can't do any of this stuff and it's just going to move smoothly to now I can do all of this stuff. It's going to be ups and downs. And if you've given them that background, you're talking around that background like, hey, I know things are going well now, but there could be a time when we push too much, when we, step on the gas a little bit because you got to get back on the field for a given season or timeline. All of a sudden now it gives you the leeway to maybe make a mistake and still have that level of trust with your athlete, because otherwise if you had told this athlete we're going to go from A to B to C and it's going to be totally smooth, now all of a sudden when you hit that speed bump, that inevitable speed bump, if it wasn't discussed prior, all of a sudden now the athlete's like, what the hell is this guy doing? I thought this was going to be smooth. Let me look for another PT or something like that. So important to keep that in mind, but that is how I would balance pushing an athlete forward and trying to mitigate the risks of overloading that athlete. Okay, next question. How has your approach to rehab or athlete care changed since you first started practicing? So when I came out of graduate school about 15 years ago, I often talk about this on the pod. I took a job in what was called an orthopedic/sports practice, but in actuality, it was very general orthopedics. And I took that job because they paid the most, and they paid the most by about $1,000, $2,000. What a freaking mistake that was! But needless to say, I get into that practice, and I was coming out of graduate school, and all I heard in graduate school was when doing orthopedics how important manual therapy is, and not just manual therapy, but let's take like specifically low back patients. For me, it was all about the sacroiliac joint. What is the innominate doing? Is it an upslip? Is it anteriorly rotated, posteriorly rotated? What are what is the fulcrum of the sacrum? How is that rotating? Is it nutated? Is it counter nutated? How much can I palpate it? Okay, let's do a muscle energy technique, reassess, get them stand up, have them move a little bit. Okay, they're better. Great. I'll see you next time. That was my world. And shame on me for thinking just because that's what was taught to me that is in fact the end all be all. I love the idea of having the ability to use my hands and help patients. I've come a very long way and a very far away. I've moved very far away from I'm going to use my hands to fix you versus this is teamwork. Whoever's in front of you is your number one teammate, and you need to work with that patient to get the results that they want, that now you want, because everyone wants their patient to succeed. And it's going to take so much work on their part. It's not just my hands. And what is the research for what it is that I was preached in school? So, how well do we actually know that a therapist is able to palpate, understand the movement of a sacroiliac joint? How much movement is there at the SIJ? Is that really a predictor of pain? And once I started to get into literature, understand really some of the weak literature or the literature not supporting these manual interventions, how much I moved away from the manual therapy only world and started sprinkling in more of, can my athlete control different ranges of motion? What is a normal range of motion? How do I get my patient to do regular maintenance? I got to call out Kelly Starrett here. He's a major mentor of mine. And thinking about what are the tips and tricks that we can give our athletes to do on their own. We are simply the guiders or the guides in this rehab journey. And so one, it's incredibly humbling because it's not about us. It's about how much they can do. Two, we are educators. And now all of a sudden my practice, my clinical practice has become far more strength and conditioning. And with that term, I mean movement coach than it is manual therapy practitioner. So I think that's one thing that I've massively changed my mind on. Could be in 20 years, I'm doing this podcast and I talk about how I got all the way back into manual therapy, but that's another spiel in and of itself to think about how am I branding myself. You don't want to really become subservient to one title or one type of practice modality, but definitely something that I've totally changed my mind on. Okay, next, what is one piece of advice you wish every patient, athlete or non-athlete, understood before starting physical therapy? I think the number one thing is when you come into my office, you are signing up to be an active participant in your own healthcare. A wise therapist once said that we cannot care more than the athlete in front of us. And so creating buy-in, creating motivation, giving them the tools to do it on their own. I wished patients knew that coming in. I think they're getting much better about it. I think there are a lot of influencers out there that are already preaching this. So I think a lot of patients do have a grasp of this, but I definitely wish they knew that they're going to play a way bigger role in their recovery than I, the therapist, will. I mean, think about how much time they spend away from you versus with you. They're going to have a bigger impact than we are. We try to educate that on day one, how important that is. Okay. Next, what is your take on rehab technologies like force plates, dynamometers, wearable sensors? Are they necessary or just nice to haves? This is a really great question. I got this from a newer graduate who's looking at opening his own practice, and I think it can be daunting. You know, you look at startups. Like I said, I got out of grad school at 15 years ago, and then it took me about 5, 6 years to open my own practice. And so when I opened True Sports, you want to talk about a shoestring budget. I mean, I did it with nothing. And I think now that's becoming the norm. Then it was very daunting to do something like that. But if you're coming out and you're looking at all these bells and whistles, you're looking at force plates, you're probably looking at $250 to $500 for a rental to buy them. You're looking at $3,000 to $5,000 to buy them. That's a big startup cost. You're looking at now Tindex. We've talked about Tindex, which are dynamometers that are fairly affordable. You're looking at a few $100, but now think about high-low tables, think about turf, think about squat racks, think about all those things that you might have to buy. It can be daunting. I would say if you're treating a high-level athlete where you really need objective data, they are must-haves with the caveat of you have to know how to use them. It does not help for you to go to a bank, get enough of a loan, or to bootstrap it and just say, I'm going to buy these things. You have to spend time learning how to use these things because it's going to make the product that you're producing far better. It's going to help your patients understand, why do I need to come back? I obviously don't have force plates at home, the patient is thinking. So it's a great reason for them to come back. But is the therapist giving them meaningful data? Is it really changing what it is I do? I'll give you a quick story. I met with a NFL team during it was a lockout, I think, not a strike. And so when I met with that NFL team, I went in and met with their athletic trainers. I met with their strength coaches. And it was interesting because no one was in the building because all the players were home. They were trying to figure out what they were going to do with the work stoppage. And so I had their undivided attention. And I go through this NFL training room and I see ultrasound machines and I see just plinths lined up. I see a giant tub of some type of NSAID where they were just like handing those out like it was candy. And in the corner, I see a stack of papers, computer screen, and like a whole bunch of cameras. And I'm like, hey, what is that? And so they explained to me something called a DARI system. This was probably 13 years ago. And I said, what's a DARI system? And they said, it's some type of markerless movement capture. I did some research on it once I left the facility. That what they had their model cost about $75,000. I said, like, how do you use it? They're like, yeah, we don't use it that much. So fast forward, now they got a sports scientist in this organization who understands DARI and uses it to allow his prescriptions to be spot on and individualized. But it makes the point that just because you have the money to buy it, you have to know how to use it. And my God, it was just collecting dust in the corner. So if you are going to make the investment, one, I would start small. Start with a Tindex and learn that stuff. We also use an app-based markerless movement capture, and it does some movement capture, but it can also give you almost all of the data that you can get from a force plate. It's called a MyJump app. Costs a couple bucks a month. You just have to learn how to like use your iPhone or buy an iPad. Far more affordable. But the bottom line is you gotta know how to use these things, and once you do, I think they are a must-haves. But I would start really small and not fall for, let's say, the force plate salespeople that say this is an absolute must. Okay, how do you individualize your approach for each patient, especially when many injuries seem similar on the surface? So this harkens back to the first question I answered, which is just because the diagnosis may be the same. Let's take our shoulder tendonitis or tendinopathy, our rotator cuff tendinopathy in throwers. They might have that diagnosis and athlete A and B, same diagnosis, our interventions should be very specifically tailored to the deficits we find in our evaluation. I think this is where a lot of graduate schools kind of miss the bullseye. This is where, hey, here's how you treat the pathology. That is totally wrong. The pathology can guide an understanding of our explanation, but it doesn't tell us what is wrong with the patient. What is wrong with that patient could be stiffness at the glenohumeral joint, could be poor scapulothoracic control, could be poor T-spine extension, flexion, rotation, could be an issue with the hip. Although I get nervous about moving very far away from the target area too quickly, but it could be all of those things, right? So same diagnosis, but different approach. And so that's how I'm very careful with, yes, this is your pathology or your diagnosis. Yes, your MRI said you have supraspinatus tendonitis. I'm going to fix it a myriad of different ways. I'm going to fix it or educate you how to fix it based upon your objective evaluation or the deficits we can pick up. And then this is very important, especially to all the new PTs out there, be able to explain your intervention, whether it be what you're doing with your hands, why you're doing it, what you're doing with the exercises in clinic, why it's going to help them, what they are supposed to do for it at home, and why it's going to help, and then be very specific with how you teach them how to do it. I've seen time and again athletes come in seeing other PTs. They've heard about True Sports. They come into True Sports. When they come in, I go over their past home exercises. I think it was spot on. They're doing no monies or they're doing external rotations with a band. That makes a lot of sense, let's say, because this athlete presents with weakness of external rotation. The problem is they're not doing it well, or they're not doing it enough, or they're doing it too much. So don't take things at face value. Really get into how someone has gotten to this place and what they're doing about it, and maybe there are little tweaks you can do there. Hopefully that kind of answers how I individualize the approach. By the way, when we bring applicants into True Sports and they're applying for a job with us, we give them a case. Part of that case says they were seen elsewhere, they were doing these home exercises, and too often the applicant either totally strays from that home exercise thinking, well, if the patient isn't better, they're coming to me. It must be what they were doing prescribed was incorrect. Again, sometimes I want to see how the patient was doing it. I want these applicants to ask me to show them, because I'm playing the role of patient. Here's how I was doing my straight leg raise. Well, you're doing straight leg raise. You're giving yourself hip flexor tendonitis because your knee's not extending all the way. You're not using your quadricep. You're using your hip flexor. You have to be able to spend time with the patient and ask them how it is they were doing their homework. That is going to be how you individualize. Because the second you say to that athlete, hey, your last therapist, they did a good job of prescribing the right exercise, but actually they're probably giving you hip flexor tendonitis, or you're giving yourself hip flexor tendonitis. Here's how you should be doing it. Here's why that matters. You need that terminal extension so that you can get all of your quad recruitment. You can get back to blah, blah, like that whole spiel. That makes you a sticky clinician. That's going to ensure the patient comes back to you for visit 2. More importantly, you're going to get more bang for your buck. The athlete's going to get better faster. That's the way you individualize care. And the second you individualize care, compliance goes up and your reputation will spread and you're going to be able to help more people. That's what it's about. Okay, what advice do you have for someone dealing with a persistent or chronic injury that hasn't responded well to past treatments? I think this dovetails beautifully into my last answer. You got to analyze their past interventions. You got to stand on the shoulders of others. You got to understand, well, there's no reason to just start from scratch. Look at what they were doing. I think that's going to give you your best chance. It's a very similar answer to the previous question. Okay, in your opinion, my opinion, what makes a great physical therapist beyond just clinical knowledge? This is one of my favorite questions. So, Lacey in Texas, thank you for sending this in. Lacey, I hope you're listening to this. I'm looking for someone, I'm looking for a physical therapist that can read the room. That's number one. Do you understand that the patient in front of you is not just a textbook or a mock example? This is a human. This is a human that wants to get back to something. This is a human that's not performing to their optimum, and you're there to help them. So can you read that room? Can you be empathetic in the way you're delivering information? And then what I'm looking for for a PT that comes into True Sports is how excited are you to be in this model? And so if you're looking for, you're bouncing around jobs and you want to work at True Sports or you want to be a PT because you think it's a good way to earn a living, because you want to start here and then let's say move to a professional sports team. I'm going to be able to smell that immediately. So is the patient in front of you. You need to understand where it is you're working and be excited to work there. And it's our job to test for that. How can we tell if you're excited to be there? How can we tell that you're willing to go the extra mile for your patients? That is what I wish PTs knew, that is way more important than how well you did on your boards or even the rotations you did when you were in PT school. It's way more about the personality, your ability to connect with the patient in front of you, that interests me and I think makes a great sports PT. Okay, how do you handle professional disagreements or turf wars between PTs, athletic trainers, other healthcare providers, most notably surgeons? I would ask everyone listening to this to scroll back up in Spotify or Apple Podcasts and find my conversation with Dr. Kendra Lennon. Dr. Kendra is a PTAT. She's dual certified. And I posed this question to her because I have gotten into it in the past with other athletic trainers where I just didn't understand where they were coming from clinically, or they were very territorial, or maybe I was very territorial about my athlete. Here's what I want done. Here's what I think they should do moving forward. This needs to be collaboration. So, two pieces of advice to break down some of these silos and barriers. Number one, what is most important? Is it my ego? Is it the ego of the athletic trainer who I'm communicating with? Or is it the athlete? And if you're going to be a great sports PT, it has to be about the athlete. So if it's about the athlete, you sure as hell better figure out a way to communicate appropriately with the surgeon, with the athletic trainer. So that's one. Two, really piggybacks on number one, be humble. The conversation I have with an athletic trainer is not about me showing them, I have a doctorate in PT, you have a doctorate or master's in AT, here's why PT is better. It's not about that. You have to be humble when talking to any of these other clinicians, understanding what they can bring to make the offering better. I think if you have those two things in mind, all of a sudden these turf wars, they're just going to go away. And when they don't, when that AT hasn't listened to this podcast and they're coming at you with some type of ego, or the surgeon comes at you with some type of ego, I would advise you to just let them. Just let them do that, because it's not going to help you to fight back. What you then have to do is think, what can I do? What can I do in this situation to allow for the best outcome? And if that's being humble and quiet, great. If that can be sticking up for my athlete, great. If that can be showing and talking calmly with the surgeon to understand, hey, like I've been spending 6 months with this athlete. Here's what I'm thinking. Let me know what you're thinking. This is why I don't think they're ready necessarily to go back to sports. That's putting the athlete first. And if you can do that in a humble way, all of a sudden, a lot of that territorial nature just falls away. Okay. How do you manage your own energy, boundaries, mental health while working in a high demand, people centered job? I think it's really important. I spend all day, every day in people's face. I always give my buddies crap because they might walk into their office, sit behind a computer, have a given amount of tasks to do, work through, and then coming out of that day at work, now they're ready to interact and be social because they weren't social all day. If you're a sports PT, you are social from 9 to 5, or you're social from 7 to 4 p.m. You're doing 8, 9, 10 hours a day of interacting and talking. And if you are an extrovert, then awesome. Maybe you're ready to go home and throw back a couple beers, hang out with your buddies. That's not me. So when I'm at work, it is important that I'm social, engaging, effusive, being an extrovert, because I think that breeds an environment where people want to come to. But I also know that I need to recharge. And so my weekends look far more introverted, because I know that's what I need. So I'm reading, I'm working out, I am doing things that fill that bucket, um, that are going to pull me out of that need to be extroverted, so that I know come Monday morning, I can come back, and really provide my best self there. It's not for everyone. The question was like, how do I manage it? That's how I manage it. Um, I've made mistakes in the past. I used to fill that time alone with reading, but I was reading business. I was reading clinical stuff. I was trying to get better at my field, and I have found far more success starting to read other things, whether it be things on meditation, now history that I'm reading, which is fascinating to me because I think it gives me just a better understanding of different parts of the world and where people came from. Also, wise advice that I got from my most successful patient ever. He lit my ass up for not knowing what was going on in the world at the time. He was a finance guy. He would read 5 to 10 newspapers a day. So now I spend the weekend kind of catching up on what's going on outside of true sports, what's going to make me a little bit more well-rounded. That brings me comfort. It also allows me to relate to anyone that's in front of me. Hopefully find something in common. Maybe they're from some far-flung place in the world, and you know a little bit about what's going on there. Maybe they have different hobbies, interests, feeling. If you can make yourself a little bit more well-rounded, I have found success that kind of fills my cup on the weekends. But I think it's really individual. But thank you so much for that question. Okay, let's wrap it up with the following. I got a couple more questions that I thought were interesting. One is, what's one myth or misconception about physical therapy you wish you could erase from the public mindset? And I think this is a great one. This is a great one to wrap up on. I wish the world knew, and I think there are a tremendous amount of people now online shouting it, that physical therapy is not just for the injured. Everyone needs our skill set. Everyone, as we get older, and I'm talking when you're going from 15 to 20 or you're going from 40 to 60, you have to keep up with motion. You have to understand how the body should move. You have to understand how to stay strong. I highly recommend reading Peter Attia's book Outlive, because he really talks about well span and the ability to age well and be able to enjoy everything that is great about our lives later into life. That starts today. It doesn't matter how old you are. It starts today. It doesn't matter how old your patient is. So I wish the public knew, in order to do that well, to have the help of people with our skill set, whether you're listening to this pod and you're a strength coach, a PT, an athletic trainer, we are movement experts. We know how the body should move and how to optimize movement, and everyone can use that. That's why I see the future of this field looks like dentistry. What do I mean by that? Everyone needs a dentist. Everyone knows what good oral health is. For some reason, dentists have done an unbelievable job to say, I am your dentist, so you need to see me twice a year at a minimum or something like that. PT is just the same. And it looks like this in other places in the world. Talk to Dr. Tim Stone, who's straight out of Perth, Australia. He'll tell you the way it works in Australia is everyone has a physio. They go in for regular checkups with their physio. PT is no longer for the injured, it is for those who want to thrive. And arguably, that should be everyone. That's myth one. Myth two, we don't have to wear khakis and a goddamn polo to work every day. Dress like the population that you're treating. If you're working with athletes, you should be dressing like an athlete so that you can move, because we're movement experts. We need to be able to move ourselves. All of that should be bundled in the myths that I wish were dispelled in the public eye about our profession. All right, guys, thank you so much, for listening to all of this pontification. Thank you for dealing with my incessant nasal voice. Hopefully, you got a few pearls here. I am dying to know what you think about these solo pods. I'm dying to know what you think about our pod in general. We're here to serve you. We're here to make you better clinicians, maybe even better humans, just better able to succeed in the field of physical therapy, strength and conditioning, athletic training. And along those lines, we're always looking to grow. So we're up to 15 clinics now throughout Maryland, Pennsylvania, Delaware. The only way we're able to do that is by hiring outstanding physical therapists. We're up to about 70 physical therapists, and we're always looking for more because, like I was explaining, if we can dispel the myth that PT is only for those who are hurt, think about how many people need what we do. Thank God True Sports is kind of getting that word out there. So if you want to join our team, just shoot me a DM, True Sports PT on Instagram. I would love to talk to you, see where you might fit in, see how you can help True Sports grow and all of our athletes and patients, and vice versa, how we can help you. That's why we're doing this pod. I can't wait to hear from you guys. Thank you so much for listening. Bye-bye. Bye-bye.